हेलो गुड मॉर्निंग, मैं सिर्फ डॉक्टर आर्यन और आज हम डिस्कस करेंगे मेडिसिन के न्यूरोलॉजी सेक्शन के सब इंपॉर्टेंट एमसीक्यू। विच ऑफ द फॉलोइंग करेक्टली डिफ्रेंशिएट एल्जाइमर्स फ्रॉम पार्किंसन? लो डोपामाइन लेवल, प्रेजेंस ऑफ लिवी बॉडी, डैमेज्ड nucleus of Maynard Besalis, decreased thalamus activity. Here the correctly differentiate from Alzheimer to Parkinson disease is the damaged nucleus of Maynard Besalis, because in Alzheimer disease the neurotransmitter acetylcholine decreases. Acetylcholine is synthesized by the nucleus of Maynard Besalis, which is damaged in this disease. This disease of acetylcholine further leads to various degenerative changes in the brain. In Parkinson's, substantia nigra is damaged. Next question. A 75-year-old banker complains of increasing difficulty buttoning his shirt every morning and brushing his teeth. He states that his hand shakes while relaxing in front of the TV, but stops while reaching from the remote and switching channels. Which of the following is the next most appropriate step in managing this patient? Deep brain stimulation, send him for cognitive behavior therapy, prescribe L-Dopa, prescribe mementamine. Here the best answer is the prescribe L-Dopa, because given the symptoms including difficulty with fine motor, task and resting tremors that improves with purposeful movement, this patient likely has Parkinson's disease. L-Dopa is the main step of treatment for Parkinson's disease, as it helps to replenish dopamine level in the brain, elevating motion symptoms. Initiating of L-Dopa therapy can significantly improve the patient quality of life by reducing tremors and enhancing motor function. And in the deep brain stimulation can be done in Parkinson's disease patient when medically therapy fails. And cognitive behavioral therapy has no role in improving Parkinson's symptoms. Next question. A 55-year-old male with a history of Parkinson's disease abruptly discontinued his levodopa carbidopa therapy due to fears of side effect. Shortly after, he manifested severe muscle rigidity, hyperthermia, confusion, elevated heart rate, blood pressure fluctuation and profuse sweating. What is the most probably condition this patient experiencing? In the neuroleptic malignant syndrome, NMS is primarily associated with the use of antipsychotic medication, which block the dopamine levels receptor, particularly the D2 receptor. This blockade can lead to dysregulation of the dopamine transmission in the brain and contributing to the development of NMS. Additionally, abrupt withdrawal or reducing of dopamine agonist medications such as levodopa, carbidopa therapy used in Parkinson's disease can also be precipitated NMS due to the sudden damage in dopamine level. The hallmark symptoms of NMS include severe muscle rigidity, hyperthermia, altered mental status, is also known as confusion and autonomy instability, elevated heart rate and blood pressure fluctuations, sweating, etc. NMS is a medical emergency that requires immediate attention and typically involves hospitalization. So here the best option is the neuroleptic malignant syndrome, because the confusion is shortly after it manifests muscle rigidity, hyperthermia, confusion, elevated heart rate, blood pressure fluctuation and profuse sweating. If we want to, the treatment of neuroleptic malignant syndrome involves halting the suspected neuroleptic medication, and if the withdrawal of dopaminergic drug triggered the syndrome, reinstituting then promptly. And if the supportive medical care including hydration and managing hyperthermia is crucial, bromocriptine we need to grip are commonly used to pharmacological treatment, while other dopaminergic energy agents or adjunctive medication may also be considered. Next question. A 60-year-old male present to the neurology clinic with complaint of tremors, bradycardia and stiffness in his limb. He reports difficulty in initiating movements and experiences tremors primarily in his hands. At rest, on examination, the patient demonstrated cogwheel rigidity, and a shuffling gait. What is the likely diagnosis of Parkinson's disease, Alzheimer's disease, cortico-basal degenerative syndrome, and myasthenia gravis? What do you think is the Parkinson's disease? Because the Parkinson's disease is a neurodegenerative disorder characterized by the classic major symptoms of tremor, bradycardia, slowness of movement, rigidity, and postural instability. Tremors in Parkinson's disease typically occur at the rest, often starting in one hand or foot, and prognostic in involving the other limb. In the bradycardia, refer to the slowness of movement and stiffness and rigidity. Can be demonstrated by the cogwheel rigidity, which is a characteristic feature seen in Parkinson's disease. Other common signs include a shuffling gait, difficulty in initiative movement, akinesia, and reduced arm swing while walking. Next question. A 65-year-old male patient with a history of Parkinson's disease present to the neurology clinic for a follow-up visit. He has been on levodopa therapy for several months, and the clinician is discussing potential side effects for the medication, except dyskinesia, nausea, orthostatic hypotension, and obesity. Here the answer is obvious. Obesity, because obesity is not typically listed as a side effect of levodopa therapy, while weight changes may occur in patients with Parkinson's disease due to the various factors such as change in appetite, diet, habit, or physical activity levels. Obesity itself is not directly caused by the levodopa medications. The side effect of levodopa like that dyskinesia, nausea, vomiting, and orthostatic hypotension. Next question. A 40-year-old man is brought to the doctor by his family for rapid intellectual decline. His wife states that he used to be fun and lively and has become verbally and physically aggressive. Examination shows fast semi-perpetual movement in his hand. His father and grandfather had died for a similar illness. Which of the following is the most likely diagnosis? Early onset Alzheimer's disease, Lewy body dementia, cortico-basal degeneration, and Huntington chorea. Here the used of the symptoms become verbally physically aggressive. This is the Huntington chorea. The autosomal dominant disorder. Condition is a family history of the similar disease is always present. Here we need to see that his father and grandfather died from a similar illness. Similar illness is seen in the Huntington chorea autosomal dominant disorder. It is caused by the trinuclear repeat expansion in the Huntington gene found on the chromosome 4. And the decreased level of the acetylcholine and gamma aminobutyric acid GABA are seen in the brain. Neural death occurs due to the glutamic acid toxicity via the NMDA. DNA testing can confirm the diagnosis on neuroimaging atrophy of caudate and putamen with subsequent ventriculomegaly is seen. Symptoms appear between the age to 20 to 50 years and include chorea. Huntington chorea is fast semi-perpetual movement. It can involve the face, head, neck, tongue, trunk, and extremities. It presents an abnormal involuntary movements with advancing age, chorea, reducing and dystonia, rigidity, and myoclonus appear. Depression, dementia, and intellectual decline are key features. Incontinence and atherosclerosis, slow continuous involuntary within movement, altered behavior, aggression, irritability, personality changes, antisocial behavior, obsessive compulsive feature, and psychosis. And gait is unsteady and irregular, bradycardia and rigidity may occur. Next question. A 35-year-old male present with weakness persisting for 3 months accompanied by tongue fasciculus plus deep tendon reflex at the knee and muscle atrophy in certain region alongside spasticity which additional test in warranted for the patient considering suspected ALS, VP, MRI, whole spine, CT, whole spine, electromyography. Electromyography is the test done for the ALS is the first line of the investigation. ALS is a neurodegenerative disorder characterized by the death of the anterior horn cells in the spinal cord, and there is the brainstem homologous innervating the bulbar muscles, and progressive weakness affected the segment of the body. Asymmetric limb weakness most common. The asymmetric limb weakness in the upper and lower motor neuron sign. In upper motor sign is the spasticity, hyperreflexia, dysphagia, lower motor side atrophy, fasciculation, hyporeflexia, weakness. And the diagnosis of the ALS is the peripheral nerve conduction studies and the electromyography. Thank you and keep revising.